What about serological markers? You've got soluble fast ligands, such as which is referred to as FASL and interleukin 10 levels. Now, FAST regulates the clonal expansion of autoreactive B cells, and binding of FAST with its natural ligand actually triggers apoptosis. If you have a patient with higher serum interleukin 10 concentrations on admission, that is suggestive of bad prognosis. Higher peripheral blood, Th17 cellular activity and lower T regulatory cells, bad prognosis. Then you've got a giant cell myocarditis with no or limited immunosuppressive therapy. Again, a bad prognosis. Then you have got associations with celiac disease and myocarditis between celiac disease and myocarditis, which is actually a bad prognostic variable. If you've got a high titer of organ-specific anti-heart antibodies and anti-nuclear antibodies, it's a bad prognostic variable. Then there are other markers as well, wherein you get a patient with recent onset diuretic cardiomyopathy, less than 6 months. Then giant cell myocarditis with no or limited immunosuppressive therapy, or a necrotizing eosinophilic myocarditis. All of them have got a bad prognosis. When it comes to management of these patients, it is basically the standard therapy for acute and chronic heart failure. That is what we need to use. And what does that mean? If you've got a hemodynamically stable heart failure with decreased ejection fraction, that it would mean that you would use diuretics, you would use ACE inhibitor, or for that matter, an angiotensin receptor blocker, and evidence which favors an appropriate beta blocker, namely in the form of carvedilol, extended release metoprolol, or for that matter, bisoprolol. You can add a mineralocorticoid receptor antagonist, such as spironolactone or eplerenone to that, especially in those patients who have got a persistent symptomatic heart failure with a left ventricular ejection fraction, which is less than or equal to 35%. Then you have digoxin, which actually provides symptomatic benefit in those patients who have a systolic heart failure. But the problem is, we are talking about heart failure. Now, heart failure and myocarditis are technically two different entities, and there is no interchangeable trait here. I mean, digoxin, for that matter, cannot be used to that effectiveness in myocarditis vis-a-vis heart failure. What are my other therapeutic options? Putting these patients on a mechanical circulatory support, of course, one. And if the failure is intractable and if it becomes irreversible, then probably the next thing that we should be thinking of is a VAD or an ECMO, that is a ventricular assist device, or putting these patients on a VA ECMO, that is ventricular arterial ECMO, so that heart gets rest and actually it can be supported for a long time altogether. You can go ahead and use antiarrhythmic therapy as well as the rate control options, depending on your need and depending on what the clinical situation is. You can actually go for it, especially if you're getting more of arrhythmias. If you've got those patients who have got life-threatening ventricular arrhythmias, who have been receiving optimal medical therapy, and who have actually got a reasonable expectation of survival, along with an expected good functional status, which can last for more than a year, then probably ICD implantation is something that should be offered to these patients. If your patient is having a concurrent complete heart block or symptomatic bradycardia, these can also be treated by pacing, and these are actually the indications for pacing. If you've got a patient who has got systemic embolic phenomenon or acute left ventricular thrombus, this is also an indication of anticoagulation. What should I avoid? NSAIDs is one, definitely. It gives rise to fluid retention. Second is heavy exercise, especially for those patients who are actually symptomatic. Heavy exercise should be avoided, and heavy alcohol intake, of course, should be absolutely avoided. Any other drugs? No, you can go ahead and give immunosuppressive therapy. Immunosuppressive therapy would take the form of either steroids, mycophenolate mofetil, cyclosporin, or IVIG. But there is no clear-cut evidence base which actually says that giving these is very, very good or giving these is beneficial. In addition to that, you can get specific therapy, which is directed at mycoplasma or Lyme disease if it is present there. When we talk in terms of further course, most of the patients with acute myocarditis have partial or full clinical recovery. However, in some cases, this process may actually continue subclinically, and eventually it will become severe enough to produce symptoms and end up with a dilated cardiomyopathy. So what would happen in these patients is at some point in time, sorry, either they would need mechanical circulatory support, one, or a ventricular assist device, two, or thirdly, they can be put on VA ECMO till the point in time these patients can be taken up for heart transplant. What should be my ideal follow-up interval? Actually, it should be initially at intervals of 1 to 3 months. And at all these intervals, I should be repeating the echoes for these patients, just to get an idea about the disease progression and about the disease prognosis. In addition to that, you can do a cardiac function assessment at 1 month or 6 months. And along with that, afterwards, you can put this on to an yearly follow-up. So most of the things, I mean, for myocarditis is like this only, and we've covered it fully in terms of covering the topic from head to toe in terms of myocarditis.